Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner by sitting down with people who have interesting careers, important lessons to tell, or inspiring stories. I hope that you learn something too. If you want to support the podcast, please follow or subscribe on your platform of choice. You can also like or comment to boost the algorithms or share out to your network to make sure it gets more views. But ultimately, and what I hope you choose to do, is listen to the very end. With that, we'll start today's podcast. Hello, everyone, and welcome to this week's episode of the No Bad Questions podcast. My guest today is Dr. Steve Kim. Dr. Kim is a pediatric urologist and co-founded Voluware out of his own frustrations with the impact of prior authorizations on his patients' care and his practice's finances. Dr. Kim was previously an attending surgeon at Children's Hospital Los Angeles, an associate professor of clinical urology at the USC Keck School of Medicine, where he served as CHLA's Director of Clinical Research Informatics for the Southern California Clinical Translational Science Institute, CTSI. That is a NIH-funded research data consortium. Dr. Kim is passionate about helping to improve access and the delivery of high-quality care for patients, and I've asked him here to educate those of you who don't live in our space that he and I live in on prior authorizations, what they are, why you care. And so, Dr. Kim, thanks for joining me here on No Bad Questions.
Yeah, thank you, David. I appreciate the opportunity to speak to your viewership and help educate a little bit about prior authorizations.
So let's start right there. What are prior authorizations?
Yeah, so prior authorizations are these insurance transactions that physicians have to do. And the best analogy that I've really come up with over the years is really think of it as like a permission slip. So if I, as a doctor, wanted to treat a patient and recommend a surgery, get an MRI, recommend or prescribe a medication, my office staff literally had to fill out what amounted to a permission slip. So in my office, that meant filling out fax forms, literally with all the information, or having to type into a whole bunch of different websites and asking the insurance company, hey, can I do this? Or is this going to be something that will be covered by the insurance so I can go ahead and proceed? And, that ended up being a massive problem for me treating my patients, as you can imagine. But just the enormity of like how much extra, paperwork was involved was really kind of crushing my team at Children's. So yeah, that's a little bit of prior authorizations. It is really meant to put in check. I think they want to control what services are being done and how much money is kind of going out of the door as an insurance company. And so that's kind of what prior authorizations is. And I know you and I both live in the same space, so you've got your own probably words about prior authorization. So, but that problem itself, I started looking into it when I was first asking my office manager, hey, what's going on? Why is my patient not getting scheduled or having their surgery canceled all the time? And she literally kind of pointed me to this problem. So it's been it's been a decade-long journey for me to try to fix this on behalf of the patients I was treating, but also kind of for providers who struggle with this every day.
And I think it's becoming a larger and larger issue. And I think there is more and more attention being paid to it. I've read some things recently as of this recording that Medicare is going to try to address it. And I don't know if those are going to go far enough or too far. That probably depends on where your political hat falls or whether you work for an insurance company or for a practice or something like that. But I particularly like the phrasing that you've got there of permission slip, because it has just the right sort of patronizing tone towards a physician from the insurance company. I actually, because I've talked to a lot of docs and they feel that way. It's like the autonomy is being taken out of their hands is what is often felt. And do you feel that, let's back up. You talked about where they came from to try to control spending or perhaps fraudulent spending. Not all providers and hospitals are upright moral actors, right? There is waste, fraud, and abuse. But do you feel like we've perhaps passed beyond a point where it is reasonable to control expenses and has gone to, at least in some scenarios, an unreasonable approach?
Yeah, no, certainly it is, I think, grown from something that was probably well intentioned for a lot of what you pointed out. You know, not every physician, not every practice, not every hospital is necessarily doing, their best to to do what is appropriate. Sometimes that
Hmm.
does happen. Unfortunately, this is like one of those examples where, when you do have some bad actors, run afoul of the rules that all of us are kind of subjected to it.
Right.
And then the other part of it is there's like a real kind of cost concern in the United States around how do we start controlling costs. And the estimation is that roughly about, last time I checked, it's probably over this now, about 3.5 trillion is spent on healthcare.
Mm.
And so we do have to do something to help control costs over time. And so that was, I think, the original genesis is one, preventing kind of wasteful utilization, as they call it, or fraud. But then over time, really, how do they start controlling costs to make sure
Right.
that it's has some semblance of being affordable? Although I don't know if anyone who's I've spoken to can say that their insurance premiums seem like they're affordable for what we're getting. And so that's really part of it. The other part you go back to about just the implications and kind of the tone or what the perception from providers like myself are around prior authorizations. Look, I spent 13 years in medical school and training and
Hmm.
fellowship to then have to, that's like a lot of training and a lot of experience going into kind of what does a patient need in my best medical professional judgment.
Right.
One would be told by someone who has no experience really in pediatric urology, saying, "Oh no, you can't do that because of a rule internally that they've decided." And so there's really a huge disconnect for a lot of us physicians about we've taken a Hippocratic oath, and we're trying to adhere to doing what's best for our patients, but then feeling incredibly handcuffed about helping to treat our patients the way that we feel like we need to, right? And there's a huge cost consideration in that. Now, I don't think that we can go to an environment. I know a lot of my colleagues on the provider space want to get rid of authorizations altogether. That to me, and this goes back to a little bit of my research background and something called value-based healthcare and what's called health services research. Like, it's not an unlimited budget, right? And we can't cover everything for everyone. And we do have to make some hard choices. And this is what the insurance and medical directors do have to do, of like, what do we spend the dollars on? What's going to be the best application to make sure that we're covering and treating as many of the people as we can with the dollars that we have. Now, there's a lot to be said about how do we feel about, is this just kind of a way to play defense on dollars so that they can retain earnings for shareholders? Those are a lot of the kind of more, contentious conversations that are out there.
Sure.
But one thing that, having done this for 10 years, understanding what is the mechanics, what do people have to do every day, is there's fundamentally a flawed and broken system of how we're actually doing the transaction of prior authorizations, right? Because it's so archaic, outdated, and an incredibly expensive activity. And so that's really kind of what I decided to start fixing inadvertently in my own office when I started across this problem about 10 years ago.
Okay. And you said a couple things in there that I want to follow up on. One of them is about the sort of more fractious argument, and I'll admit that many days I feel this way, that it's a tactic to maximize shareholder value. On the other hand,
Mm-hmm.
that is the sort of one of the responsibilities of a for-profit entity. So I can't necessarily blame an insurance. I mean, I could be upset about it because I work on the provider side, but I
Mm-hmm.
can't blame them for doing that. I think the real responsible party in this is the customer, which is not the patient. It's the employer. And I think if they want to minimize the risk of delayed care, they need to look at how they structure their benefits with their plan manager. But
Yep.
that's a whole separate conversation, probably with an insurance expert.
Absolutely. Yep.
So let me then back up and say, okay, I'm a patient. I'm listening to this. Sounds like a bunch of bureaucratic stuff to me. Why do I care if I'm from the patient's perspective?
Yeah, I mean, this is it. You're, as a patient, directly impacted potentially by prior authorizations, right? So, there are a lot of surveys that have been done recently by the American Medical Association, surveying physicians about kind of the impact on patient care. So, you know, 93% of physicians, and kind of I know this and I experience this every day, where a prior authorization workflow or process actually delays patients from getting care. So
Mm.
there may be instances, depending on the hospital you work at, where you can't schedule an MRI until you get the authorization secured. So that can be, depending on the insurance company, it can be a day. Or sometimes on a rare occasion, you can get kind of an automatic approval, but sometimes that can be 14 days before you can actually even get scheduled. So then you're starting to talk about waiting that time to get the approval, then scheduling,
Mm.
and then you're starting to add that up. That becomes an impact of patient's care, right? And
Right.
I've been a part of that as a physician, super frustrated at the fact that there's a timeliness to care, especially for patients who are cancer patients. Like there is something about getting things done in a timely fashion because time matters, and so that's one aspect of it. The other part of it is, a lot of things just don't get approved. So you may not get the care that, I as a physician think that you should be getting after, having almost 20 years of experience in practice, because of kind of this artificial, insurance paperwork process and approval process, right?
Mm.
So there's actually some good, survey information from that American Medical Association calling out that about 80% of patients or physicians feel like our patients have kind of abandoned care or not even gone through it because the headaches are so
Mm.
severe around prior authorizations. And that's a huge impact because we're trying to prescribe the care that we think is in the best interest of patients. They're trying to follow up and do what the doctor is telling them to do. But then there's all this kind of these barriers kind of put in place amongst some of it. It's just time. My practice where I was at the Children's Hospital, my population was, a lot of what we call the Medicaid population, where they don't have the means to kind of advocate for themselves and follow up. So one of the things that really struck me was just how many of my pediatric patients' families would just not, advocate for themselves and continue to fight. So then I see them a year later, and suddenly like things have gotten so much worse. So
Mm.
there's a real kind of meaningful impact that can happen to you as a patient if you're kind of involved with an insurance company that has these prior authorization workflows. Another thing they've actually talked about is, and this is something I personally experienced, and maybe this is what kind of was the last straw that caused me to do something about it, was, about a third of physicians surveyed said that we've all experienced cases where our patients have had a significant and severe adverse outcome, like something really bad happened to them
Mm.
as a function or, what we believe to be as a result of a prior authorization workflow
Wow.
causing that. So, from a patient care standpoint, adding this additional layer of paperwork and bureaucracy can definitely impact, your care as a patient. And I talk to a lot of people both in the profession as well as my friends and other family outside of healthcare, and it's increasingly becoming hard to find someone who hasn't been affected or has known someone who's been affected by kind of prior authorizations. The other practical financial part of it that people may not understand, and you, David, probably know this better than anything, is that if your insurance company, if the paperwork isn't in place for that authorization, and let's say Dr. Kim orders you to have a certain surgery and that gets done at a hospital, sometimes the insurance company will say, hey, we never approved this, so we're not going to pay for it. And then you got to go back out to the patient and say, hey, the insurance company isn't going to pay for this. Here's this bill that we want to work with you on. And sometimes that
Mm-hmm.
can be so, both, my priority is obviously from the patient access side of it and getting the care that they need, but there are also financial implications involved as well.
Thank you for that rundown. From a patient's perspective, one other thing that I've heard of that's starting to appear, and I'm interested to get your opinion on it, that could impact patients. So you mentioned that they could get a bill, so it's financial. They could have a delay in their care, so that's the clinical timing. But one of the things that I've heard starting to arise is authorizations for some providers and not others as a way to sort of steer patients to certain types of service providers, to a non-hospital, to an imaging center, to a surgery center. So my question there is, A, are you seeing that as well in the work you're doing, sort of independently? And B, do you feel like that is something that is meaningful or a patient, or to the assertion of the insurance companies, is it, an MRI is an MRI is an MRI?
Yeah, so I think we see it a lot with some of the clients that we work with insurance companies redirecting to a different site of services, they call it. So, I schedule something for my hospital that I work at, for an MRI or as an example, and the insurance company will approve it but they'll approve it to a different location, obviously for cost purposes, right?
Hmm.
So, in theory, quite you know actually it's probably cheaper to do it at certain locations,
Hmm.
in terms of the cost of a study. And so there's a lot of that activity. We see a lot of that activity around pharmacy medications, where insurance companies are doing requiring you to not be able to fill it at certain pharmacy locations and having it to go to their pharmacies, which is a lower cost point, called brown bagging or white bagging for infusion medication. So there
Right.
is a lot of cost, behind, I think, some of the decisions that they want to try to steer people into. Now, I'm not going to weigh in on the qualitative. Is it better to have an MRI at one, location versus another location? Certainly, every provider, every physician probably has their own personal opinions, based on kind of their experiences. And, and there's also a convenience factor built in. So sometimes it is more convenient to have a study done sooner at a more closer proximity location that's like an ambulatory imaging center. So, but the fundamental backdrop to all that is a lot of it is driven by cost, right? They want to
Hmm.
place patients in kind of a lower costs, service location, and the question is, I think as long as it's the same level of care or quality, then that's not as that's something that is certainly okay. But sometimes this gets extrapolated to, they don't want to have a cancer surgery done by Dr. Kim at a certain hospital because they have someone else who's in their network who may not have all the years of pediatric urology experience, who may be a general urologist, that potentially can do it because it's a lower cost point. So there's a lot of you know dollars behind some of these decisions, which is very frustrating and unnerving. But it is part of the reality of the world that we live in today with the insurance, the way the insurance system's designed.
I I appreciate the essentially the point that there's too much nuance to weigh in from one community to another, from one doctor or one hospital to another,
Mhm.
on a broad basis about whether different settings are going to matter, but the breakdown of how that site of service approach can work. The something you mentioned in there that I didn't necessarily have on our radar to talk about today, but I think it's worth pointing out as well, is that brown bagging phrase. And
Yeah.
that one worries me. I'm willing to go on record and say I don't think that's safe for patients.
Mhm. Yeah.
Um, but for folks who are listening and don't know what that is, can you just what is brown bagging?
Yeah. So, this usually is around kind of higher cost medications that get infused into patients. So, like, you're getting an IV and you're getting injected the medication. So, typically a physician would order, for, a medication for therapy, and it would get dispensed at, the pharmacy, oftentimes connected to the hospital. And all that is under, the infusion gets done, the medication's being provided, and so that's kind of the typical way that things had been done for a long time. But the concept around brown bagging is that, the insurance company would point you to a pharmacy, where they would dispense it. But literally, the reason they call it brown bagging is they would take your medication, put it in a brown bag, wrap it up, and give it to the patient, to then take to the infusion center to have it infused. So there's like this extra step, which, I, in many ways agree with you, of like, you're asking the patients to properly handle medication that is incredibly expensive and
Hmm.
incredibly important to them, to have them bring it in and to remember to bring it into their infusion, appointment, so they can actually get their medication. So, and that's really, a lot of that is also, I think, obviously driven around cost. We do find that a lot of insurance companies will have pharmacies that they either own or have close relationships with, that will dispense at a likely a lower cost point, right? But the added level of confusion and stress to the patient, if you can imagine a cancer patient who's been told that they need to pick up a medication. This isn't always going to be kind of necessarily chemotherapy, but medication that they have to go to a separate kind of pharmacy to go pick it up and remember to refrigerate it or bring it to their next appointment. That's a lot to be asking of patients, and there's always kind of the opportunity for something to happen. So that's yet another example of some of the manifestations around authorization. So like from an authorization standpoint, you would potentially get an approval, but it has to get shipped only to a certain pharmacy that would get approved. So you have to get directed in that direction. So yeah, so we certainly run into that with some of the clients that we work with, amongst other things.
Yeah. The proper handling in the chain of custody is what makes me worried about that. If something needs refrigerated, I mean, how many people have accidentally left the milk out
Yeah.
overnight, right? And
Or
sure, the medicine is more important, but you forget things sometimes. And if you don't handle it just right, and then you're going to put this, either that whole drug's going to go to waste, or you're going to put it into your body, and
yeah,
makes
there
me anxious.
makes a lot of us anxious, and it's additional kind of additional logistics involved, right? In terms of, as you said, the chain of custody of the administration of medication. So,
Well, let's keep moving through. So we've talked about some things. What is prior auth? Why does a patient care? Some of the hazards there, and some of the reasoning. I mean, I get some of the reasoning,
mhm.
but so how did it become? Because I've read some stats that we've gone from a few very expensive procedures need prior auth to a large number today, and we've gone from this world. I think my perception is where a lot of those were, if a prior authorization was not provided, and one were to sort of appeal that, it's usually back in the day, I'm going to say, it would not necessarily be overturned because it was for sound reasons that it was not granted. And today I've
Mhm.
read stats that something like 80% for some services, no, you
Mhm.
can't have that procedure or that medicine. We appeal. Okay, fine. You can. So how did we get to this point where it's so cumbersome?
Yeah, you're absolutely correct in the fact that when it first started, it was really just for the highest of high cost services, that were, and some of it, quite honestly, was not clear as to whether or not how beneficial it was. So there was
Mm-hmm.
a good reason to actually have this process in place. But over the years, it just seems like it's become utilized more and more as a cost control or containment tool, which it is, and it has become more broadly applied to all sorts of different services. I think the number that in the figure that you're quoting is a recent Office of Inspector General report when the Medicare Advantage plans were looked at as to what their behavior has been around prior authorization workflows. And what they found was even 13% of what Medicare says you have to approve and what is medically necessary were being denied by some of the plans. And on top of that, as you pointed out, 80% plus of what was denied by these Medicare Advantage plans was ultimately overturned and on appeal. So the question really is, was that just a tactic to kind of delay things? If you were actually going to appeal 80% already on the grounds of if we provided the information, it got approved. And so there's a lot of obviously suspicion around kind of what is the motivation from the insurance company side around that. And I think it's becoming an area that's increasingly under the microscope from regulatory agencies, both the federal government as well as many of the states, as to kind of what is happening with the prior authorization process. Um, you know, we have certainly seen a lot of that type of activity where things can get appealed. It's just,
Mm-hmm.
as simple as trying. And so, the question that everybody asks is that intentional? I can't necessarily tell you what's on the other side of that fence, but yeah, there's certainly a sense of that when you start seeing certain patterns, right? So typically what happens if you do get a denial, and, for physicians who are, like, my patient does need this service, it goes through kind of an onerous appeal process. So we're asked to kind of either supply additional information to appeal it, and sometimes, quite honestly, from the payer's perspective, like if the physician's office isn't giving them all the information, or a doctor didn't actually document all the
Right.
information that they wanted to, absolutely, there we see a lot of those cases too. So it's not necessarily the fact that they don't, that it's completely unfounded that they want more information, but it goes
Mhm.
through appeal process. We provide more information. If it gets denied again, then it can go to something called a peer-to-peer review. And that in itself is a huge problematic process where, it's me, the physician, having to talk to a medical director on the insurance side who's to kind of, talk it out as to whether or not why this is being denied, or why it should be approved. And, that is a very challenging process because, one, the logistics around it are incredibly challenging, right? Because it's like, trying to schedule between a busy surgeon's time
Yep.
to get on the phone call at times that, that they're available can add additional delays to it. And the other thing that I've quite honestly found, and I think you'll read a lot about this in the state regulations that have been passed or going through the different various state legislatures, is that there have been times where I'd get on a phone for a peer to peer as a pediatric urologist, and the other person on the other side of the call has no idea about anything about pediatric urology, right?
Mm.
So, and so these are very frustrating conversations for many of us physicians, where we have these conversations to advocate for our patients as to why we think that they need a particular service, just to have someone across on the other side making this decision who has little to no practical experience in our specific fields. And I understand that, like, you can't necessarily expect the medical directors to have deep knowledge in every specific nuanced subspecialty. So I understand that limitation and challenges, but that's like a deep frustration. So going back to the start of the conversation, I did all this training. I'm I think I know what I'm doing, and
Mhm.
just to be told that no, you got to explain this, and these things are just additional kind of pouring more kind of salt in the wounds, if you will, to a certain degree, around the frustrations with prior authorizations.
Personally, I would challenge one thing in what you just said, and I really appreciate you running through that. The one thing I would challenge is you said we can't expect these medical directors to have deep experience, and my thing would be I think we can, because that prior auth is essentially saying you shouldn't or can't perhaps um, do the thing you want to do.
Mm-hmm.
Well, the reasoning behind that should be deep seated in medical knowledge. You know, to me, am I wrong in feeling like that is a reasonable table stakes situation?
So I completely agree with you that that should be the expectation.
Mhm.
But this is where I'm going to kind of layer in a little bit of my prior research background in
Mhm.
generating. So I did a lot of time trying to generate evidence based literature. So we do need good literature to say, is something actually what should be done in
Mm.
terms of guidelines. And so there are definitely areas in the different medical fields where there's actually good guidelines that everybody kind of agrees to. There are companies that create kind of clinical guidelines that a lot of the insurance companies will use. The federal government and the local governments will also create guidelines, or what are known as national coverage determinations and local
Mm.
coverage determinations. But that only covers a small segment if you look at the broad scope of medicine, of good agreed to literature about what should be done and what shouldn't be done in terms of the clinical guidelines. So this is actually what you're uncovering is a massive challenge in the U.S. healthcare system design, is that a lot of these areas are completely gray, right? A
Mm.
lot of them are even areas around treatment where sometimes, even within my own practice that I was at, where we had a whole bunch of pediatric urologists, sometimes we had disagreements as doctors, individual doctors, about what is the appropriate treatment, right? So that's kind of natural to happen. And so, yes, absolutely, I think we should have an expectation of having someone with knowledge to make those decisions, for sure. But there's also a little bit of it where, you know, there are a lot of gray areas, right? And we don't have
Yeah.
great literature or evidence to prove one way or the other for a lot of it. And so, medicine is always evolving and literature is always improving. And so it is, that should be the expectation. I know a lot of the states have passed legislation around prior authorizations, kind of mandating that the review has to be someone in your specialty or similar to your specialty, which is a definite step up. But there is also this practical challenge that there are so many things out there that maybe don't have clear guidelines that everybody can agree to. So it's really up to the medical directors on the insurance company side to do their level best to kind of dictate what policies are out there. But if you don't have a whole bunch of evidence for certain things one way or the other, then there's a lot of interpretation and kind of leeway that can be applied, right? And then sometimes the medical director you're on that call with is not necessarily in your specialty. They're just kind of reading off the playbook of this is what our medical director has said. So
that makes a lot of sense. That ties back to recently I read an article. It was either in Time magazine or from the New York Times about this patient who is a student who is suffering, fighting to get their medication. And I believe it was for some sort of autoimmune disease. And their physician had written off label, for a really high dosage of something. But that was the only way this person got results. But because it was off label, it was not approved at that dosage for that condition, for, those circumstances. The insurance company was saying, we're not going to pay for this, even though it was clinically effective. And so that was a really fascinating article. And I think it ties directly to what you're saying about there may not be the research-based evidence to support something. And that actually brings up, I don't know if I've ever thought through this before. So forgive me, Dr. Kim, and listeners, for me thinking out loud here, but I've heard often physicians say it's the art of medicine or the practice of medicine, not the science. And yet prior authorization is algorithmic. It is a playbook, as you said. So is it just that we have, perhaps the problem is we've got rigidity that we're trying to apply to a practice of medicine, to the art of medicine? Could that be part of where we have so much friction here?
Yeah, no, certainly, absolutely. And for anybody who's like taking care of patients, there are things that we're all kind of taught in terms of care guidelines, but we all know that every patient's unique, right? They all have a set of circumstances, and in your job and your role and kind of the oath that you swore to, the Hippocratic Oath, was like taking all of your knowledge as a provider, as a physician, and then figuring out a way to do what you can in your best opinion to treat that patient. And that's a classic example of, if you went strictly by the guidelines and the rules and the dosing for that particular patient, you're absolutely correct. That's not in the playbook. That's not in the guidelines. And so, I think that's what kind of triggers them to say, hey, what's going on now? But, we frequently run into these cases where, from our own individual and collective experiences as physicians, we're going to say, hey, we've tried everything. I have seen this work before in another patient, or I've heard about it at a meeting, and I think this is the best chance, or the only chance that we have for a patient to kind of get to a better place. And so we'll do that type of work. And so, there's also kind of the concept around off-label that you mentioned. So even the FDA has kind of said this is the appropriate dose that they've kind of approved, but we do have that. As physicians, we have the ability in the best interest of the patients to occasionally use something off label, right? So to say, hey, look, we think that this is, something that may be helpful. And obviously that comes with its attendant risks for going off label. But that happens. And so it goes back to the question about, we don't have the perfect rules for everything in healthcare. It's just too impossibly complex to have that. And I think what you're seeing, a construct with imperfect evidence and, and with a lot of judgment, where the gaps are kind of filling in kind of that process around prior authorizations. Now, there's a whole separate massive problem in prior authorizations, which is just how the mechanics of it work. And so what I've always been focused on with the approach at our company is we can fix that. There's a lot of stuff that can be done around that.
Hmm.
And the hope and goal is that by saving the excess money that goes into kind of wasted costs around that, we can actually hopefully cover a lot more care, right? So that's, I think they're two separate but highly intertwined things that you're talking about. There's one aspect that is just totally around the absurdity of the mechanics of how we actually do the whole process of prior authorizations. And then secondly, there's a harder problem to solve is, and this is a bigger US healthcare system is, what care should people be able to get with the limited finite resources that we have available, right? So that's a
Yeah.
whole different question. And that's even getting stretched even farther because of the fact that a lot of the amazing medications that are coming out are life changing potentially, but incredibly expensive, right?
Right.
So that's kind of a those are decisions that we're going to have to make collectively as a country. Is like how do we manage that? We can't afford to pay everybody to get a $2 million drug per dose, right? So that's a whole different thing. But there's an entire mechanics of how prior authorizations are administered that I think there's a lot of opportunity to kind of improve and make better.
I have a theory, and I'm interested to bounce it off of you, to see if you think it would be viable and would help solve for this. Given the amount of these prior authorization denials that get overturned, and given how it can delay care, and given how burdensome it is, and given the state of technology and the large language models we're seeing, the ability to parse, large amounts of data very quickly,
Mm-hmm.
if I had a magic wand and could wave away everything on the front end on prior auth and move it to back end audits. And then the provider carries some risk. You better document well. You better
Mm-hmm.
do care that is reasonable and actually chart it in a manner that is going to explain your clinical, your medical decision making. But if we could move all this to the back end, I think my theory is we'd still be able to get some of the cost containment. We'd still be able to detect the fraudsters who do exist, sadly, but we would also be able to get rid of some of the risk to the patient. What do you think of that? I mean, I truly would need a magic wand to make that happen, but what do you think of that theory?
No, I mean it's certainly a theory that may be applicable to other cases with kind of retrospective review, right,
Mm-hmm.
of kind of documentation and claims. I don't know if the payers will kind of go on board with that. So, that's another. There's a whole kind of financial risk that's involved. I think that would be kind of an ideal. Well, it's certainly an improvement to kind of the current front end mess that we have, right? So,
Right.
I don't know how all the participants and stakeholders would kind of negotiate how that whole process
Fair.
would work out. So a fundamental kind of we don't believe this, we're not going to pay you for that, but there's a lot of, I think, a lot of contention in that approach. I know it does happen for other types of workflows where it is based on a retrospective review, whether or not things are approved and denied or paid or claim payments essentially. So that's actually something that's been intriguing and actually brought up at another organization that I had interacted with called NAHAM, or the National Association of Healthcare Access Management, where
Mm-hmm.
that exact concept was brought up and floated. And this is a big enough problem where I think we should look at all potential solutions. And I don't
Yeah.
think it's going to be a magic bullet. I think it's going to be a collection of working and grinding on a lot of different things to get this to the place where it needs to be. And so, absolutely, that's another thing to put into the discussion around prior authorization reform. I mean, ideally, if we could all kind of have our wish, is that, and this also includes the insurance company. So I think there's, the future prospects of like, could we get it to a place where this could be automatically done at the point of documentation, right?
Mm.
So, as a physician documenting it and kind of having the capability to be able to automatically decide and have much more of an instantaneous reaction or decision around authorizations. And I think, that is something that I would like to see. I just
Yeah.
know the practical parts of getting all that information structured to get it to that place. We're still, there's still a lot of work to be done, right? And that's actually part of what we're looking to do is to build that infrastructure. So at the heart of a lot of the problems with prior authorizations is, yes, there's the whole kind of, application of the decision making about, what is clinically appropriate, but there is so much problems with something called interoperability of just
Mm,
getting information from, an electronic medical record to the insurance company so that they can actually make that decision. And, that's kind of the space that we play in. There's a lot of opportunity, and we're actually, in fact, helping to, from our perspective, actually make that bridge to the electronic transmission so that people can start applying newer technologies to help, automatically adjudicate and give a response kind of in much more real-time fashion. So, we're very excited about working on that with actually kind of a national health plan as well. So there's that opportunity to get there. And there's also the
yeah.
opportunity to take off the low-hanging fruit. So there's certain stuff that we know, we've been told by some of the insurance plans that they don't want to go through the whole rigmarole of making people submit information just to say we're going to approve it because we kind of know we're going to approve it.
Hmm.
But there's that fundamental like last mile of making that connect in the electronic health record and then also the billing systems that is still not there. And I think there's an opportunity there to like start taking some of the low hanging fruit off, and then we can ultimately focus on the more challenging questions to answer about high, really kind of experimental, higher cost medication. So I'm very bullish on what technology can do in the long term, but there's got to be this. We need some fundamental building blocks. I know everybody tried to jump to AI and machine learning,
Hmm.
but they didn't realize that the data structure itself is incredibly dirty.
Yeah.
So it's kind of like the Tower of Babel, the old, the kind of old passage about all these different folks that are they're trying to do the same thing, but they can't communicate with each other because they don't speak the same language. And in many ways, kind of developing kind of a something in between like a Rosetta Stone to help translate the information so that people can actually do what they need to do on both sides is kind of, that's, I think, kind of from a helping with the actual practical workflow part of it is kind of what we've been looking at. So yeah.
All right. Let's let's round out the conversation then, to because we've talked about a lot of stuff we've had planned to. One of them is we've talked about appeals, and you had talked earlier about patients self advocating. What is the
Mhm.
patient's role in all this, and how can they self advocate?
Yeah, I mean, it's a great question. I get asked more and more, and I see a lot more of this. And the first thing that I would recommend to patients is just to be aware of it. So if they are having something done, a procedure, having a study, to ask, right? So because I think the first part is just being informed that this is something that you're being subjected to as part of your care. And most patients probably don't even realize that this is happening in the background until they're very frustrated and calling the office saying, "Hey, what's going on? I haven't gotten the schedule." So just to be aware of that more, and ask your provider as to what's the holdup, and be aware of that. Aside from that, like, it is difficult to necessarily, as a patient, directly influence that process per se. There are things that can be done indirectly or through different channels to help appeal, if you will, if it gets to that
Hmm.
point. There are certain states like the state of California where I am, where if you go through an appeal process and you're still frustrated after the appeal gets denied, you have the right to have it go to an independent medical review board, right? So a third party that's supposed to be able to arbitrate between the insurance company and your physician or provider and say, hey, look, we're gonna kind of make that determination. The other thing that people may not be aware of is that on occasion, as a member of a health insurance plan, you may get a survey, a kind of a customer satisfaction
Hmm.
survey that you get surveyed on, called a CAP study. And there are passages in there that are supposed to kind of ask about experiences around your access as a patient with the referrals and with prior authorizations. And people may not think that that counts, but it actually does, and here's why. So those CAP studies are what the government, CMS, utilizes to give what's called a CMS star rating. So
Hmm.
when you go to shop for your, Medicare Advantage plan at the end of the year when it's open enrollment, you're going to see, okay, this is a 4-star plan, this is a 3.5-star plan, this is a 5-star plan. Well, those consumer surveys as well as provider surveys that are done actually factor into how they calculate that CMS star rating. And every half point of those stars that go down for that reason, for any reason, translates to lost dollars for that insurance
Hmm.
plan, right? So there is that reflection point. Um, I believe with the latest iterations, they've actually increased the weighting on patient access in the survey. So referrals and authorization related activity is actually being increased in terms of the weighting. So that is another way. And so, don't necessarily throw away that, or don't do that assessment if you do get asked to do that. So that's another way to do it. Maybe a sad reflection of where we are today around the prior authorization process is with a lot of what I'm seeing and hearing about is patients who are beyond frustrated taking to social media in a kind of an effort to publicly shame insurance companies. And so that certainly does happen. I think it's insane that that's kind of the only recourse that patients have, but it is something that I'm seeing increasingly happen, and to try to kind of advocate for themselves. I think from my own, oops, sorry,
No, you're fine. Go ahead,
patients
please.
was just it's hard, and it's hard to advocate for yourself when you don't know all the different things that are going on. So I'm hoping that with this podcast and other things that we can do out there is to help educate patients to be more educated about what they can do potentially, or be more understanding of what they're signing up for around those requirements. So yeah, that's what I would kind of suggest for patients to you know be more proactive about in the course of their care, that you run into a prior authorization as a challenge.
Well, Dr. Kim, I appreciate you joining me. A lot of the bare bones facts of what we talked about, I knew, but I wanted to bring your knowledge out to the audience, such as I've got one out there.
Mhm.
But I also wanted to challenge myself to think, and you've certainly helped me think about a couple things in this space. And so I appreciate from both angles you coming on and sharing your wisdom and sharing your experience with me here on No Bad Questions. Thank you very much.
Yeah, no, thank you, David. I appreciate the opportunity, and I think there's a lot that all of us have to do to help advocate for a better process and a better system. It is impacting patients far too often, impacting providers, contributing to burnout and a whole bunch of other things that we need to start turning the tide on. So yeah, happy to be on this podcast. Look forward to any other questions or conversations that may come up, and yeah, appreciate the time.
All right. Thank you much. And thanks everybody for listening. Bye now.
Thank you, everyone. Bye.